Okay. We all set to go?
Yep.
Hi, I'm Jill, and this is a Zoom meeting with Dr. Emani about the Bivent program. And yeah, I think that's all I got right now because I can't find my information. So if you want to take it from here, that would be awesome.
Great. Well, thanks everybody for listening in, and I wanted to share a little bit about where things stand with the biventricular repair program. But start off for those who may not be familiar with it. What is the biventricular repair program, and what is it that we do? So probably in the early 2000s, we started to realize that single ventricle management had issues that not all kids, but some kids started to face. And when we started to see some of our children growing older into adolescence and young adulthood, and coming back with problems, particularly after a Fontan procedure, with complications, we started to ask the question: is there an alternative? Is there another way to really manage the heart defect and help these kids to avoid a Fontan? And this really started a chain of events. And a number of organizational efforts to get everybody together to think about this. And our first procedures were done in the early 2000s, where we started first with patients with hypoplastic left heart syndrome. This is basically the condition in which the left ventricle is underdeveloped. And that was sort of the initial attempts at doing biventricular repair were in those patients. After we started to have some success with it, actually my mentor, Dr. Pedro Del Nido, started this whole program, but I started to really expand it to other indications and to put together a team. And right now what we have is a team of individuals that are really dedicated to helping families think about alternatives to single ventricle management. Our team includes myself and Dr. Eric Fines as the main cardiac surgeons, although all of the cardiac surgeons here do it the way that we work is that if a cardiac surgeon at Boston Children's is doing a biventricular repair, we present it at our conference, and either one of us are involved. We also have a group of cardiologists who do imaging, very specifically detailed and geared towards thinking about biventricular repairs. And I think that's really important as we realize that not every echo is the same, not every MRI is the same, and there are really specific pieces of information that we need to get that we can't get unless the imaging is done right. And so that's been important. And then in terms of interfacing with families and trying to coordinate our program, we have a group of individuals, and on the call today are Jackie O'Brien and Sume Portuguese, who are BIV coordinators. They help families kind of get in connection with us so we can get all of the imaging information into our system so that we can see what's there and make evaluations. And they also help coordinate our families who are coming back ultimately for repeat evaluations. We've recently added on now a group of physician assistants who are going to be involved with a lot of the post-operative follow-up and making phone calls to families, because many of our families may not be from the Boston area. So trying to really have a comprehensive follow-up program. So that's a little bit about who we are. Our ability to do a biventricular repair in patients with quote single ventricle has really expanded enormously over time. As I mentioned earlier, it started with patients who have hypoplastic left heart syndrome, but now has included patients with other types of defects, including unbalanced aortic canal defects, complex transposition of the great arteries, straddling valves, double outlet right ventricle, double inlet left ventricle. And so increasingly we're finding that what we thought was dogma, what we thought couldn't be done any other way, it had to be a single ventricle, it had to be a Fontan, actually have other options. And there are ways to sort of avoid the Fontan procedure if done right. It's clearly something that we're still learning. So a lot of what I describe when we talk about biventricular repairs are really relatively new, and so we have to keep that in mind anytime we're making a decision in a child about whether we do a biventricular repair, whether we try to head down that pathway towards a biventricular repair, or whether we go down the Fontan route. I think we've started to really realize that rather than thinking about this as being a binary decision, it's not like, are we going to be a biv or are we a single ventricle? But what can we do to bring clarity to the situation? What are ways in which we can better understand how a child's heart is capable of handling circulation? And that's something that we have utilized more commonly for all of the different types of congenital heart defects. And this is something called a staged procedure. We might call it a staged procedure, staged ventricular recruitment. These are all kind of within the same rubric of gradual loading of the heart and a gradual way to work towards biv. So it's not like all of a sudden you're going to a biv and the heart has to handle it. And this is something that we learned over the years, and so this is something that we're employing more commonly. So when we talk about the various types of congenital heart defects and how we do the repairs, this is something that we're going to be revisiting and talking about. How do we stage this so that it's less sudden of an impact on a child? So what I'm going to do, I'd like to open it up to questions, but what I was going to do is to talk a little bit first about an example of a type of congenital heart defect that we have been doing a staged ventricular recruitment on. And I'm going to just because I haven't presented to this group on this particular congenital heart defect, I'm going to talk about double inlet left ventricle today. And this is something that this is a program that we really started about 4 years ago. Again, it always starts when a child comes to us with risk factors for a Fontan, and so we think that they're not going to be a great Fontan candidate, and so we start to think outside the box and say, are there things that we can do? And I remember about 4 years ago, I had a child with double inlet ventricle who was not a Fontan candidate because of bad leakage of the valves. And we were talking about, what are the other options that we could do? And I remember, talking to this family really extensively about trying to do something different to create a ventricular septation for double inlet ventricle. And I'm going to describe a little bit about what this is and how this works. But that patient actually did really well with it, and since then we have expanded now to doing this even in patients who are Fontan candidates, so as an alternative to a Fontan, even in low risk patients. So I'm going to share my screen, and I'm just going to talk through. Jill, can you enable share screen so that I can share my screen.
And is that something you need to do? Because I made you host now. Okay, thanks.
I think you actually have to do it through your. See if you could do it now.
Okay, great. Okay, are you able to see my screen of a heart?
We're seeing
Okay,
her.
so I'm going to first describe what
I think we're actually seeing Jill's screen. So,
are you not seeing my screen?
no, we're seeing Jill's screen.
And let me try this again.
Now we are seeing yours.
Okay, great. So this is double inlet ventricle here. Basically what it means is that you have the heart, chamber is here, and normally when you have a heart chamber, there are two separate ventricles, and there's a right ventricle and a left ventricle that's separate, and then there are the two inflow valves, mitral valve and a tricuspid valve that enter, and then there are two outflow valves, an aortic valve and a pulmonary valve. But in double inlet ventricle, that septum is missing. There isn't a septum in the middle, and in fact, both of the flows from the mitral and the tricuspid valve come in to essentially this single ventricle like this, so that all of the blood flow returning back from the lungs goes into the, so the lung vessels are here, all of the blood flow comes back from the lungs and mixes in with the blood flow that comes from the lower body here and the upper body here. And all of that blood flow just, essentially mixes together. So the pink blood or the red blood from the lungs, comes through and mixes in with the blue blood that is coming back from the body. And then they mix up, and then together you have this purplish blood that that essentially goes out to both the lungs and to the aorta. And so this is kind of the basic findings of a double inlet ventricle. So the heart, this heart beats and kind of pumps the blood out, but it pumps the blood out into both of the chambers, and so the oxygen levels are low. And so our traditional management for a patient with this type of defect then is to do the Fontan procedure, and that's kind of the classic the classic operation that has been done. So usually what is done at the first procedure is something called a pulmonary artery banding, which is where we put a little constriction on the pulmonary artery to limit the amount of blood flow that goes to the lungs. And we do that because if you don't do that, then you'll end up with too much blood flow going to the lungs. So that's usually done in a neonate or in a young child, to kind of limit the amount of blood flow. And then at about 4 to 6 months of age, we start, what we call the partial ventricular septation. So what we're going to do at this operation is we're going to place a partial patch inside the ventricle that separates this ventricle into two ventricles. But it's not going to be a complete separation because we don't want to make one side of the heart be higher pressure than the other side of the heart. And so we're going to leave a gap in it, and that gap is going to allow blood flow to basically go between both of these chambers. But what this partial ventricular septation allows us to do is to have blood flow to stream more appropriately. What does streaming mean? Well, pink blood coming back from the lungs will go down through the mitral valve into the left ventricle. Some of it will go over into this new right ventricle, but for the most part, all of that oxygenated blood will be going out to the body, so that the oxygen levels in the body will be sort of in the 90% range, okay? Whereas the blood flow that is that's coming back from the lower body, and in some cases the blood flow coming back from the upper body will flow into that right-sided chamber. We close the hole in the atrium so that blood flow can't really mix very well at this level. All of this blood flow coming in, some of it, a little bit of it may go over to here, but for the most part, all of it still goes out and into the lungs. And so this is kind of getting close to a more normal circulation, but we haven't completely separated. So this is not a biventricular repair yet because we still have a hole in the heart. This ventricle together, those ventricles are still pumping to both sides of the body. But it does one thing, and that thing is that it gives us an oxygen level that is 90%. So we have a little bit of, we have better oxygenation, and we have, more leeway in terms of the circulation. Okay. Now, once we do this, we kind of can allow a child to grow, and so with time, what we find is that as a child grows, and the ventricle will start to grow, but this patch here in the middle will stay the same size, and that's important because we don't want. We want to kind of grow some septum. We want this patch to anchor onto the heart muscle, so that it doesn't allow the heart to just enlarge over time. This patch kind of holds on to things. You can sort of see it here that the heart kind of grows, and as the heart grows, this patch stays the same size, and that hole stays the same size, but we kind of start to grow some septum because this piece of patch is holding on to that heart muscle, and so the heart muscle basically grows over time. We can then come back at a separate operation, usually a couple of years later, to then close this remaining hole that's inside the ventricle. So now we have really completed a biventricular repair, because now all of the blood flow coming back from the lungs will go into the body. We take away the band from the pulmonary artery, and now all of the blood flow coming back from the body, which is the blue blood coming back, the low oxygen blood comes back and goes into the right-sided ventricle, and then out through the pulmonary artery, and then all of the pink blood that's coming back from the lungs goes into the heart and then gets pumped out to the body, and then now essentially your oxygen levels come all the way up to 100%. Now, this is obviously not every patient will be ready to go to this, and the important thing is that we're not forcing every child to end up with a biventricular circulation like this, because well, it may not be right for every child, but at least we can start by doing the staged ventricular septation, and if we do the staged ventricular septation, and there's a demonstrated improvement in the size of the ventricle and the function of the ventricle, then we know, yeah, we can go to the full BIV. if it doesn't work, then we can stay in that staged fashion where there's streaming of blood flow. The oxygen levels are 90%. The pressure in the liver is low, so you avoid the complications of the Fontan. But you basically you're kind of in halfway in between a bivent and a single ventricle, but that still, I think, is better than potentially going to a Fontan where you have higher pressures in the liver. So how have we done? Well, we've now done somewhere around 20 surgeries on children for staged ventricular septation, which is what we're calling it, for double inlet ventricle. So either double inlet right ventricle or double inlet left ventricle. There have been no cardiac transplants or mortality from the procedure itself, which is very important. As we're introducing a new procedure, the bar is very high, right? Because a Fontan actually is a pretty low mortality operation. The issues are long term, but early on the outcomes are pretty good. So we really need to make sure that that when we're doing this, that we're not causing any harm. And so this is something that that we're keeping track of. We have needed a pacemaker in one patient, and so that's something that we have to keep track of. But in general, now with intraoperative conduction mapping that we're doing in the operating room, where we can actually measure the conduction system, we've been able to avoid injuring the electrical system in most patients, and we've been able to avoid the Fontan in in a large number of, and basically all of these patients. None of these patients have had a Fontan at this point. And so as we continue to develop this program, we're obviously we're learning as we go along, because our oldest patients are now 4 or 5 years out, and we're continuing to see reasonably good outcomes overall. Of course, not every patient is going to be a candidate for this procedure, so it's really important that we do an evaluation, and the evaluation typically involves an MRI or a CT scan to look at the anatomy and to get a better sense of whether we can place the patch. And so we'll start with an echocardiogram, and then if it looks like that's favorable, then we'll move to an MRI and a cath, and then do the procedure. So this is kind of that pathway. So I'm gonna stop sharing. I'm just gonna stop at that and open up. This is just one snippet of one type of program that we're doing, but I'd like to have just open up for discussion, not just to talk about double in the ventricle, but to just to talk in general about the BIV program, about questions that you guys might have about biventricular repair, or whatever it is that's on your mind.
I've been sticking some stuff in the chat because it's easier to type as you're talking, so I know what to ask. One of the questions I have are there any valves you were most concerned about during the process? Because sometimes the valves look like they're okay, then as it goes, you might start to see some issues with them. Are there some valves or problems that you say, okay, this is it, we can't do it, let's not keep pushing it? And if there is, are there some you feel more comfortable replacing as the process goes on to kind of continue doing it, or is it just hard nose?
No, that's a great question. The valve is a very important. Both valves, the inflow valves and the outflow valves, are very important. And one of the things that we're evaluating on the MRI is where the valves are, how they look, and where the patch is going to go relative to the valves. You're absolutely right. There are some situations in which the valves may have crossing cords that prevents us from placing a patch in between, or they may have a common attachment which can interfere with the patch. And so those are all very important to know about ahead of time. And to help plan with things. I think we've gotten really good at valve repair techniques over the years. And so what I've found is that we're able to work with the valves and work around the valves to make them work well. But it is certainly a risk. So there are in this group, in this cohort, there are probably 3 patients that had valve leakage going into the operation, but continue to have valve leakage afterwards that we've been either managing medically or had to adjust with the valve repair. We haven't had to replace any of the valves yet, but it's certainly something that could be an option or maybe necessary. I would say that I would try to do as much as we can to avoid valve replacements. We like to repair valves and keep native valves because obviously as a child grows, a prosthetic valve won't grow with the child. And so having a native valve is really important to me. And if we can repair the valve, that would be important. But what we'll do is when we have the evaluation, what we'll typically do is say, okay, this is what the valve looks like. These are the risks. We talk about it ahead of time. And in some situations, when I'm counseling my families, I'll say, you know what? There's a high probability that I could distort the valve with this procedure. Let's think about whether we still want to pursue it and start with that set thresholds. I don't like to be dogmatic, whether it be everybody needs a single ventricle or everybody needs a biventricular repair. That's just, it's too much of a one-minded approach. I like to think about it as, let's really tailor our therapies. We have more treatments. We have single ventricle. It's a mode of treatment that may be appropriate for certain patients. But we have other tools. Let's see which one fits best for that child, and use time to get to know that child's heart and what it can and cannot do, and whether it be the ventricles, whether it be the valves, or whether it be the diastolic function. All of these things, we have to really think about when we're deciding what the long-term best solution is going to be.
Speaking of long-term, with some of the older bivents, not necessarily DILV, but just bivents in general, there are known issues with fontans. Like, we know that no matter what you do, they're eventually going to live with damage. There's also plastic bronchitis they can have, PLE and all that stuff. Are there anything you guys are noticing long-term with bivents that seem to be more bivent particular that they should watch for or that they should expect? Like, is there more electrical damage? You guys noticing they need more pacemakers than others or something along that lines?
Yeah, great question. I think the biggest issue that we can have with a biventricular repair is what we call diastolic dysfunction. And what this means is that the ventricles don't relax as well as they should. We can also see valve leakage over time and need repeat interventions for valve repair. I will say that we've learned a lot over time about how to diagnose diastolic function, because that's actually something that's really tough to do. How to predict it and how to avoid it. And I think that we're getting better at that. This is historically one of the things that really affected the even the midterm outcomes from a biventricular repair. Unfortunately we've lost a few of our children because of that. And we really had to kind of understand what this means. And particularly for the patients with hypoplastic left heart syndrome or hypoplastic left heart complex, they're at the highest risk for, particularly the ones who have endocardial fibroelastosis, EFE. And so in that patient population, we have really changed the way that we do things, so that we're not pushing a traditional biventricular repair, on all of those patients. What we'll do is we'll try to recruit the ventricle, see how it handles the flow, and if we're starting to see diastolic dysfunction, we are now changing our pathway, still doing a biventricular repair, but doing what's called a reverse biventricular repair, in which we're using the left ventricle to pump to the lungs and the right ventricle to pump to the body. So that's an example of something that we really only changed in the past 2 or 3 years. Some of our bivents that were done back in the early 2000s, we didn't have that option. But this is now something that we're doing much more frequently, and we've been very happy with their outcomes. So yes, it is very important to think about the long-term outcomes from the bivents. I think that we're getting better over time as we learn how to tailor our approaches. But we also know that it's important to continue to carefully monitor our patients, to have them come back for follow-up on a regular basis, so that we can look out for these problems.
I was actually just gonna bring that up, funny that you brought that up about the reverse Bivent. How is that looking? Like, how are you guys doing it more, especially HLHS? And yeah, just in general about the reverse, because I know it's pretty new, so I was interested in that. And
Yeah.
and can we do it on existing Bivents that might not be doing so well?
Yes, so great questions. I don't know how many people are familiar with what the reverse double switch is, but I can kind of briefly explain what that is, if that would be helpful. I can't recall if we had talked about that on a previous session.
I don't think we did, because that was a few years ago. We might have, but I don't know if it was done as much to bring it up. I'm not sure, honestly. But I did.
Okay, great. Well, let me actually show. I have a little animation that kind of describes what that is as well. Basically, a reverse double switch is a procedure in which we're trying to get the left ventricle to pump to the lungs, because we don't feel that it is good enough to be able to handle the circulation as it is as a systemic ventricle. So for just a second while I pull up my imaging on that.
Is the share screen still on, Anna? I can't tell.
Sorry, I'm just pulling it up. Okay. Here we go. Just give me a second. All right. Okay, let me know if you're able to see the screen.
Yep, we can see it.
Great. All right. So just going to briefly describe what the reverse double switch is. So you know, in a normal heart, the blood flow kind of goes like this. We've kind of been over this before. Blood flow comes back from the body, blue blood, and it goes into the lungs. And then you have the pink blood, which comes back from the lungs and then gets pumped out to the body. And this is sort of what we see with the normal circulation. Now, if we have a left ventricle that, for whatever reason, isn't working properly, sorry, that's me talking it through. So this is what we do at for the reverse double switch. If your left ventricle is not capable of handling the blood flow because of diastolic dysfunction, we do what's called an atrial switch operation. For the atrial switch, you're gonna take all of the blood flow coming from the lower body and the upper body, and you're gonna redirect it over to the left ventricle. So this is called an atrial switch operation. So you just basically take these tunnels and you redirect all of the blood flow coming back from the body over into the left ventricle. And now you do an arterial switch operation, and an arterial switch operation is basically where you take the arteries and switch them around. So I'll show you that here. So here are the blood vessels. You basically disconnect the vessels and you switch them around. We do arterial switches in kids all the time for certain types of heart defects, but this now basically it's called a double switch because both of the arteries and the atria are switched. And so now you have essentially the right ventricle is pumping to the body. All of the blue blood comes back from the upper and lower body, goes out to the lungs, but it's being pumped by the left ventricle, and all the blood comes back from the lungs and gets pumped out to the body through the right ventricle. So the right ventricle is now the systemic pumping chamber, and the left ventricle is a pumping chamber to the lungs. And so this this circulation is it avoids the fontan because you actually have a pumping chamber for the blood flow coming back from the body, and you have a pumping chamber that goes to the body that results in 100% oxygen saturations. So it's like a bivent, but the right ventricle has to do the work of the high pressure circulation. So we've done this now in about 15 patients, and we're doing it mostly for patients in whom we've done a staged ventricular recruitment and in whom their left ventricle just wasn't quite good enough to be a normal anatomic ventricle. There may be EFE and other things that are an issue, and we're just not happy with the numbers. And so we'll say, hey, rather than going to a bivent and risking diastolic dysfunction, let's just use it as a subpulmonary ventricle. So that's kind of the common scenario in which we're doing it. We have had a few patients who've had a biventricular repair that what we call a failed biventricular repair. It wasn't working right. And we are able to go back and turn it into a reverse double switch operation if the right ventricle is at systemic arterial pressures. That is, if this right ventricle can still pump at a high pressure, then we can do that. But if the right ventricle has become deconditioned because the pulmonary artery pressures are low, then it won't be able to handle the high pressure that's needed for it to pump to the arterial circulation. So it's really important for us to evaluate these patients, and if they happen to have pulmonary artery hypertension, then we can do this procedure. But it's really been a game changer for a lot of our patients, particularly with hypoplastic left heart syndrome, in whom we've done some ventricular recruitment, and in whom the left ventricle just hasn't been able to, reach the levels that we want. I hope that answers your question.
Jenny, do you have a question? I see the hand up there.
Hey, first, I just want to say thank you so much for thinking outside the box. I think it's that kind of thinking that gives us as parents hope. My daughter, who's actually on the screen down there, Faith, she is 27, and you had done a study, gosh, I don't even know how old it is now, about a conversion to a biventricular repair. And she's patient 7 years old. So she's Dr. Del Nito's first HLHS bivent.
Wow.
And so here we are 20 years later. And so it's just really, really exciting to hear that this is being carried over to a lot of different other procedures, diagnoses. And so we live in a little bit of a rural area. So we travel for care, and we know a lot of families who do that very same thing. And so all of these interventions aren't necessarily, as you know, commonly known about in some of the other hospitals. And so what's the best way to kind of share that message and just make sure people do know what resources are or may be available to them?
That's a great question. I really struggle with this one because, I feel like I need a lot of help in understanding how best to do this. I know that conferences and our national meetings are a way to spread the information to other professionals, but not everybody goes to conferences. Not everybody hears that, happens to hear the talk. We publish in our professional journals, but not everybody reads that particular article in that particular professional journal. And so I think it's the reason why I actually really love what families are doing and what parents are doing to educate each other, because I honestly feel that has been the most powerful, wide-reaching and impactful way for families to know about this. And I would love to throw it back to to the parents groups to sort of think about what are the best ways to help a family with a new diagnosis that's just all of a sudden being inundated with a ton of information, and how best do we reach them, and reach folks, and what are the ways in which a family who's for the first time trying to do research on this, where do they go, and how do we at least let them know this is an option. Not that we know that that's right, but at least to know that there is an option. If you think that there are other ways that we can be educating local providers. So thank you for that question. That's a wonderful question. I don't know if Jackie or Sumay may also have some ideas. They spend a lot of time sort of thinking about how families hear about what we're doing, and so I'd be curious to see if they have any comments on that.
We actually get this question a lot through the second opinion process, because a lot of our families aren't from around here. They are from rural areas in the US, and their providers aren't aware of this procedure. So they're more hesitant for them to even reach out to us and get more information because they don't know about it. But I do think working with a lot of IV moms, the best way to educate each other is through the other moms, I think, and educating the doctors and spreading the word. I think you all do a great job through the Facebook pages, the Heart Mom text groups, everything. I think it's very powerful. And I think I agree with Dr. Emani that we throw it back to you guys and whatever you think is best, we're here to support that. But we do get this question a lot. And I think it also puts families in a hard situation too, because they want to come here, but their providers don't know enough about it. So they may not be as supporting, if that makes sense.
No,
Yeah.
that's definitely one of the biggest problems, I think, is
Mhm.
I hear it constantly, especially from smaller facilities. They either don't know about it or they're outright against it. They are literally often, I hear sad amount of times they're told that they're gonna kill their kid if they come and do it.
Mhm.
That literally it's a death sentence, and they're working off of information from like 15, 20, 25 years ago, and it's just, I think it's sad that there seems to be I don't want to say an education, maybe a continuing education problem in more rural or areas who just aren't experienced in it, that greatly affects parents choices or knowledge. And I think it's sad, and I wish there was a way we could facilitate better education all around, not just the parents too. They seem to take more effort into looking sometimes.
I think it's a really, it also gets to a larger societal goal that we have at improving access to care, making sure that everybody has, that there's equitable care, and that I think that this is something that to me is a major challenge, when when there's such a discrepancy in what care providers are telling families across the country. And it's got to be confusing for a parent who's just trying to understand first what this diagnosis even means, let alone trying to sort through differences in opinions and options, and somebody saying, oh, you absolutely can't, don't do that, versus someone else saying, oh, this is the next best thing since sliced bread. And how does one make that evaluation? I think it's got to be amazingly challenging.
Well, I think though that you guys give a really good point, which is the parent groups are really powerful. And, being a parent in those, I wouldn't even necessarily think about it in that way. But what it does is it gives people hope, because there's a hope for an option. But that's what all of these procedures do, and what you guys do every day. You're always creating these new ways and looking at these new options that it gives us hope.
Yeah. What we see is, again, your families are doing a great job in getting the word out. I work a lot with international patients, and, once you have 1-2 patients that have come here, they're really good, advocates and, to get the information out. The biggest challenge, I think, for most of the parents is to find doctors that take care of your kid once they come here. So, because you will need continuous care, that, I think the education part, I think we're getting there, because you guys are doing a great job here or abroad. I think the biggest challenge I see is more like, okay, I'm going to go back, and they were not, too welcome into the idea and to start with, then who's going to take care of my kid now? So I think that's a biggest challenge. I'm not really sure how to solve that one.
Totally agree. That is definitely one of the biggest challenges. And I think another big challenge too is that sometimes you get more warnings from us heart moms who know what to look for. A lot of people who aren't used to seeing like a failing Bivent, or just like warning signs that they probably need a tune-up or something. A lot of doctors don't notice that, and it ends up causing a problem much quicker than it should have. Things that could be treated much easier if they know what to look for. That's where I think another issue with the knowledge, I think about it. It's hard because they'll come to Boston and do amazing, but they go home to a home cardiologist who either doesn't know or just kind of assumes like, oh, well, they're fine until they crash.
Well, one of the things that we're trying to do differently now, with our, now that we have more people on the team, we have 2 or 3 actually physician assistants who we're connecting with the families and using technology to create several ways to stay in touch with families after they've left the hospital, whether they're in Boston or they're across the country. It involves automated surveys and texts to sort of check in ways that are easier. One of the things that we're trying to create is a home monitoring app that will allow people to sort of, enter in weights and nutritional information, as well as vital signs and new visits and things like that. So we can kind of keep track from here, but obviously continue to have the local, your local doctors be primarily involved, but we can at least provide input in a timely fashion. So we're continuing to work on developing those resources. What I'd love to do is to get a family focus group to kind of help us really optimize it and make sure that we're taking full advantage of that capability.
Also, what about better physician to physician communication on that? I mean, I know it's pretty good, but there are some that just kind of put their foot down, or just in general, better physician set up for a Bivent, so the care when they do go home isn't so drastic.
Yeah, so I think that starts from the moment that we actually get the second opinion. It's Jackie and Sumay can talk a little bit about this, but what we've when somebody's inquiring about a Bivent, especially if their local team isn't totally on board with it yet, it creates a little bit of a dynamic, but we're trying to make sure that everybody feels like they have all the information. And everybody is here for the right reason. Everybody's here for the same reason. We want that child to have the best outcome. And if we start with that, it makes the interaction so much easier. So we can have open discussions. We're now with Zoom, we can actually have three-way Zooms where we have families and their local teams and our team together. So we do that a lot. Start the conversation before a child even has a Bivent, so that can help then set the tone and the pace for when a family goes home. That it's not like, okay, all of a sudden you have to take care of a child who has something that completely foreign to you. There's been a lot of support, and we continue to support things. So I think that's it's always, the more teams collaborate, the better the outcomes will be. It's always been the case. It always will be. We're fully supportive of that.
Oh, another question I wanted to ask was 1.5 repairs
Yes.
on any defect in general, but are you noticing that a 1.5 repair would be even more ideal than a Fontan for like HLHS, or is that basically would be like an intracardiac baffle type of thing? Like, yeah, you know what I mean? Like, what?
Great question.
That's becoming a better possibility for those who don't qualify for Bivent.
Great question. So, first of all, what is a 1.5 ventricle repair? A 1.5 ventricle repair basically means that you have the blood flow from the lower body is being pumped into the lungs, but the blood flow from the upper body goes into the lungs directly with a Glenn procedure. But the left ventricle is pumping to the body as it normally does. This is a 1.5 ventricle circulation. The advantage of a 1.5 ventricle circulation over a Fontan is that the blood pressure in the hepatic veins in the liver and in the lower body is normal. It's lower than it would be with a Fontan. So that's the advantage of it. Now, does it work? Well, we have data that shows that it does. In fact, we looked at our experience with over 70 patients who had a 1.5 ventricle repair, and what we found was that actually I'll just share my screen again. So this is the data on that. That over a 20-year period, patients who have 1.5 ventricle repair actually do quite well. None of the patients in this series ended up with having Fontan complications such as hepatic fibrosis, PLE, plastic bronchitis, all of those things. So there's something about not having the lower body, the IVC flow being passively drained. There's something about avoiding that allows us to avoid those Fontan complications. And it makes sense, maybe the pressure in the IVC being higher leads to hepatic liver and lower body venous hypertension, high blood pressure in the veins. And that's what, can cause problems. Now it's not in everybody. So I'm not saying the Fontan is necessarily bad. In fact, we have a lot of Fontan patients who are doing quite well into adulthood, but there are pretty much every patient will have some degree of liver fibrosis. That we know. But with the 1.5, you do avoid that. Now, the one thing that you can get with the 1.5 is shown here. What this is something called freedom from SVC hypertension. What is the SVC? The SVC is the superior vena cava. It's the blood flow that's coming from the upper body. That blood is draining directly into the lungs and can be at a higher pressure compared to what it normally should be. So if we have SVC hypertension, you might get things like a swollen head or a swollen upper body or headaches. And so what we realized is that with a small procedural modification at the 1.5 ventricle circulation called a pulmonary artery septation, PA septation, that our rate of SVC hypertension was much better. Basically, none of the patients who had this modification developed SVC hypertension compared to patients who did not. So we've learned a lot about how to even do the 1.5 ventricle circulations and 1.5 ventricle repairs properly. My sense is that they do quite well. There's always a chance that we can take down the glen and convert at that point to a full bivent by taking down the glen and connecting it back into the atrium. We typically do that at a time when, for instance, we are changing a conduit or doing another procedure. We can say, hey, do we really still need the glen or can we take it down? And so that's something that's always a possibility. In my mind, to be quite honest with you, I consider a bivent and a 1.5 ventricle kind of be the same thing. I think that the quality of life and other complication profile, everything is pretty much the same between the two, except for this SVC hypertension, potential, which now with the septation basically goes away. So when I'm talking to families, I'm kind of putting the two together and I'm calling them both the same. In fact, I have 2 college level athletes who have 1.5 ventricle circulations, and it's like I just feel like a lot of our patients just haven't their lifestyle is pretty much not at all impeded by having the glen in place. So so that's kind of my 2 cents on the 1.5 ventricle.
Yeah, there's been a lot of questions to complete typical biventricular repairs. There's a lot of questions about that I get from the groups, and I'm like, I don't have long-term information on that. I can't help you.
Yeah, so it is possible to do it. It does mean another procedure to take down the glen, but that procedure is not. It's pretty. If the ventricle is capable of handling that extra flow, then it certainly can be taken down.
I was just looking through the questions. I think we answered all of the questions that people were asking.
Great. Well, obviously, we're here to answer questions. Jackie and Sumay are, we can, I'm sure she'd be willing to share her contact information, because they kind of help coordinate the entire team together, and it's been very helpful as a point of contact. Feel free to email me or Jackie and Sumay, our team, and we'd be happy to kind of answer any questions that you have, or anybody in looking or watching this video afterwards may have. I'd also be very interested in starting a conversation with our community about how do we make things better? How do we do things better? How do we, whether it be from the standpoint of something from just improving access to information, all the way to how do we help Bivents after they're done, and what can we be doing better? We're always looking to improve how we take care of our kids, and so it's a team effort. We do it together, and parent groups have such a perspective that we don't have, and we're always looking for that kind of input.
No, they bring that up funny. A couple of the post questions asked more of a centralized place to have information that we were just talking about, access on a web page. Like I know there's some information on the BCH webpage, but more specific, like graphs showing like what you just showed here, but like actually on the website, and much easier to be able to access and share with others and their physicians to kind of have more detailed information that you normally kind of throw online. The super basic and then more advanced stuff, if they could access more advanced stuff, because a lot of times we're all searching around at scholarly articles and trying to share it that way, which is fine. But I think if we had a more centralized place for it, that would be really awesome.
Great. Well, that's a great suggestion. We're working on improving our website. Some of the videos that I've showed are a sneak preview for information that will be on the website. They're still kind of in the works of finalizing these videos, and I just kind of, because they've shared beta or sort of previous versions with me, I thought I'd share those. But these are currently in the works. They're being finalized and then will be available on our website. I think it's a great idea to have scholarly articles. I can pick like articles like the ones that I just showed, and put them in a library, online, we can certainly do that. But I'd also love to think about sort of, your perspective on when a family first, hears about a diagnosis and wants to learn more. Where do they go, and where should we be partnering with other single ventricle organizations to sort of say, hey, just more information if families want to hear about it, if that's where families are going to get more information, then is that an opportunity? And I just don't know. I know, of course, our groups, and I'm really forever grateful for what you guys are doing to spread the word and to highlight kind of some of the options that we're working on. But I'd love to sort of help think about that further.
A lot of them, from what I hear, just randomly come across it when they search the child's defects and the options that they have, and a lot of it isn't really detailed. They'll just come up with like a little blurb, and then they have to keep on looking, and then when they do find out that there is a Bivent option, they find our groups and other heart organizations, and it kind of goes from there. But usually when they first ask their doctor, they're shut down often, or they just say, you could try, go ahead, see what happens.
That's so true. Searching is such a big thing because I know that people, it's like those keywords, and so as those things go on the website too, whoever sets that up, that SEO optimization would be fabulous because those are the key things that we're going to be drawn to on Google. Though we all try to stay off Google, we all end up there.
I'm not afraid of, I use it and I want to embrace, we need to figure out how to embrace our information sources, but you're right, make sure that we don't get the wrong information, or make sure that the information kind of comes with the right lens and perspective so that, for instance, I don't think the Fontan is a bad solution for some patients, and I just don't want to give people the impression that that's the wrong thing. It's about making sure we're finding the right solution for that child, and that's how I try to emphasize. I do the Fontan procedure when it's appropriate and it's the right thing, but so that I think is important to to emphasize. So thank you for that.
Oh yeah, I don't want to demonize Fontans. Fontans are great for a large amount, especially HLHSers. It's kind of needed. I think maybe one way to spread more word would be go into bigger groups like the American Heart Association, that type of stuff to try and boost information about the 1.5 repairs, the Bivents and all that stuff. If it's more mainstream, I think it would spread the word more, and maybe more physicians and hospitals and parents would learn more about it.
Yeah. And also I'd love to, we're constantly, we hear a lot from families that want to undergo the Bivent repair, but face a lot of challenges in not only sort of navigating through the information and their own care teams, but figuring out if they make a trek to Boston. I mean, it's a big displacement. It's a big move, and in some situations, is the only way because the local team may not be offering it. What does that mean? How does that fit in? Is it really worth that? And I think I can provide that perspective. Only a family who's gone through it can really help a new family understand what that means. And so I would love to again have our team partner with families who are invested in helping our community to sort of think about how do we help overcome challenges for families who are thinking about this, and again, getting back to the equitable care. There are big challenges that we face currently, and we see it every day. Jackie, Sumay, and I, we constantly are we meet a lot of challenges, whether it be logistics, whether it be how do you support families that are making this big leap of faith, to financial and other things, which are a major issue, and we can't do it by ourselves. So I really look forward to getting the wisdom of the group, and so we can help our future patients as well.
Absolutely, the equity is really difficult sometimes because, especially with the more complicated surgeries, they could be there 2 weeks, they could be there 2 months, and they're asking us. A lot of times they ask, well, how long should we prepare? I'm like, you could be there for a really long time, or it could be very easy. And even if you are there a long time, it's not necessarily a bad thing. It's just hard to adjust, and the kids will eventually do better. So another thing that's difficult is you do have parents come to other centers of excellence and saying, okay, we think we can do it. And then they might not money-wise just be able to. And that's actually really difficult. If they could have more support and guidance on who to talk to, where to go, the financial support, stuff like that. One thing that's pretty interesting I bring up is childcare. There's always major issues with siblings and stuff like that. If Boston Children's Hospital could guide or help with childcare for families that are there. That's a huge drawback and really one of the most difficult things I think families have to deal with when they do come here for long term.
Well, that's these are great. I would love to kind of, open up for, a series of conversations about, these types of challenges, and these are, we could really come up with solutions to many of these, I think, together.
Awesome, fantastic. Anna, do you have any questions or anybody else have any questions?
We just have one more question from someone who said if their daughter developed a chylothorax after stage 1, should they anticipate that happening again after stage 2?
It's not always that it will happen again. And in my experience, I used to think that it increased the risk of a chylothorax afterwards, but I think it has to do with if the lymphatic system has corrected itself, if the hemodynamics have corrected themselves, then it won't necessarily recur after a subsequent procedure. However, if there is a chylothorax and if we do further investigation and find that there is an underlying anatomic abnormality that may be predisposing to the chylothorax, then that may be important to know if that could increase the risk of postoperative chylothorax again. Very good question.
Thanks. That's all, Jill.
Oh, sorry, I didn't realize my button was off mute. One question that's asked a lot is, I think a lot of them have trouble deciding with the Bivent because their child is doing so well right now. What do you think? How do we tell the parents or discuss with the parents? I can't even think of how I'm going to word it. They get really nervous beforehand, knowing that the kid is doing so well right now when they're told the surgery should be soon. How do you guys handle that? When they look great and they're concerned about going through the procedure?
Yeah, well, that's a great question. I think we face this problem not only with the Bivent, but really in a lot of congenital heart defects. We want to be, if we're going to do an operation or an intervention, we want to do it before it becomes a problem. And so the way that we try to understand this is, what is the natural history if we don't do something? And that we only know from previous patients. And then what are the risks of the procedure? And what I try to do when I'm talking to families is to say, how do we weigh those risks? Okay, what is a chance that, your child will, start to get more cyanosis or more blue or more fatigued or other things if we just do nothing or continue down the current pathway, versus try to relieve that, but then, potentially introduce another set of postoperative complications. But most of the postoperative issues are really around the time of surgery. Once you get out from the surgery, the heart's had a chance to adjust to the new circulation. Those can get better and go away, and so I try to give a feel for what that's like, but it's always hard to really convey what is it, what does a complication mean? How does that feel? How do you make that comparison to, not operating? A little bit like comparing apples to oranges. So we try to have a kind of an in-depth discussion and make sure that we're all on the same page, and just make the best decision that we can together.
And one more, all these specific question, collaterals. Do you notice there are collaterals still happening with Bivent or 1.5 repairs? The body's still kind of making those.
Great question. No, actually, the collaterals get better after a Bivent. It may take a while. So if we have a patient who's had a single ventricle, a Glenn, for instance, for a long period of time, They'll have collaterals. We try to take those collaterals in the cath lab before we do a bivent or a 1.5. But even if they do have collaterals, those will regress and regress fairly quickly, usually within the first 6 months to a year of life. Some don't always, and we may have to go back to the cath lab to take some of those collaterals, but it certainly prevents collaterals from forming. We don't see that many collaterals in bivents, long after the repair.
That's fantastic because it'll cut down on procedures, every cath, every little procedure.
Yeah.
Concern.
And that's because collaterals are really stimulated by cyanosis, by being blue. So if your SATs are, 95% or greater, then the body doesn't try to create new connections to increase the blood flow to the lung.
No, another question. If the bivents do fail, I know you guys have the heart failure team. Ava's actually on it. Do you work closely with the heart failure team and the transplant teams is that where you're learning a lot on what they can and can't handle and what to prepare for?
Yeah, what we're realizing is that there's an important interaction both before and after biventricular repair. What we realize is that being in the best shape possible going into a biventricular repair is of value. So we might have our advanced cardiac therapies team, ACT team. They kind of handle the medication management and all of the transplant and other evaluations. So we get them involved in the appropriate patients. If there's a lot of heart failure prior to a procedure, but then in patients afterwards, where we have a protocol now for monitoring, and if a child meets criteria for heart failure afterwards, then we will get our advanced cardiac therapies team to be involved. And in some situations, it may be mostly medical management, although in some situations, we may need to go to more advanced therapies. I would say that more recently that ladder has decreased significantly as we've gotten a little bit smarter at sort of predicting who's ready or not ready for a biventricular repair, and so I think that's helped significantly.
Yeah, it can be a scary word, hearing heart failure, I think, for a lot of people, but I think medically managing it, you guys have really done an amazing job learning how to medically manage it.
Yeah.
It's been fantastic, actually. I think that's all the questions that I have that everybody has asked. Do you have anything else you want to discuss?
No, I just want to thank everybody for the time and for supporting us and supporting our community and for taking care of these awesome kids. I love seeing everybody back, and I look forward to seeing it. Hopefully we can continue these. I can sort of have the rest of our team get involved in talking about the various other components of what we're doing. And again, let us know if you have any questions, and we'll see everybody soon.
Yes, I would absolutely love to. I would love to talk with the imaging and the EP, like all of that stuff that you were discussing. I would love to have separate interviews on that. That would be fantastic if we could organize that. That'd be great. And also the support size, like what Jackie and Sumay are doing. Did I say your name right? I'm sorry.
Yes, Sumay is great. Sumay, that's great.
Yes, we're here. Happy to help.
All right, thanks everybody. Have
Thank
a
you.
great day.
You too.
Bye.
Bye-bye.